So now let's hear Eloisa Tudella, who is graduated in physical therapy and physical education and has a master's in physical education from the Universidade Gama Filho, a doctorate in experimental psychology pela Universidade de São Paulo, and a postdoctorate in health science from the University Salamanca, Spain. Tudella is a full professor in physical therapy and a coordinator of the specialization course in interventions in neuropediatrics, NENEM, and of the Center for Studies in Neuropediatrics and Motricity from the University of São Carlos, Universidade de São Carlos. Dr. Eloisa research lines include characterization, detection, and physiotherapy intervention in typical and atypical sensory neuromotor development, motor performance in children with a developmental coordination disorder, and kinematics studies in infants. So, Tudella, please.
Bom dia a todos vocês. E, primeiramente, eu queria agradecer também a professora Priscila e o professor Edson pelo convite que me foi feito. Você quer traduzir?
Good morning, everyone. Professor Eloisa is thank you for the team organization from the event.
E é um prazer enorme estar aqui, porque esses encontros são super importantes, eu acho que para a formação de todos nós, não só de vocês que estão começando, mas mesmo na minha fase. Então, eu acho que é muito importante essa troca de conhecimento.
She thinks that this kind of event is very important for academic learning during the graduation and post-graduation process.
E é um prazer enorme para mim estar aqui presente, conhecer a professora Audrey e o professor Rudy. Então, é uma oportunidade única. E eu agradeço muito o convite do professor Edson e da Patrícia, para que eu possa ter conhecido eles assim pessoalmente, ouvido pessoalmente os trabalhos deles, né? E que também eles tenham a oportunidade de conhecer o que a gente está fazendo em São Carlos.
It is a great opportunity for Professor Eloisa meeting Professor Aldrich and Professor, Ruth. I forgot the pronunciation, Ruth. And she hopes that you can learn with her presentation too.
E eu vou apresentar aqui para vocês o trabalho que eu realizo há 40 anos, que é o trabalho de ensino, pesquisa e extensão.
She will present the teaching process that she has from 40 years.
Eu espero que vocês gostem da apresentação, que será a minha aluna, Meiene, que irá apresentar para vocês, porque eu não sei inglês, meu inglês é muito ruim.
So I, Meiene, I'm going to present for Professor Eloisa because of the English issue.
E então tenho aqui uma lição que vocês aprendem inglês quando tem.
So learn English when you have time.
Ok? Então obrigada. E então eu vou passar a palavra aqui para minha aluna Meiene, que é o meu braço direito, é uma pessoa que está comigo há muitos anos e tem pleno conhecimento de tudo aquilo que eu faço. Nós fizemos essa apresentação juntas, né? Então estou tranquila e sei que ela será super competente nessa apresentação.
Obrigada. So Professor Eloisa is saying that we did the presentation together, and she trusts in me so I can make a good presentation. I hope. So good morning, everyone. As Professor Eloisa already introduced me, my name is Meiene. I am her PhD student, and I'm going to talk about her work and the work of our team during this whole years of study and teaching. So, as Professor Nadia and Professor Griselda already start this theme, so we are going to talk about implications and applications of action development to early infant therapy. So, to be possible to understand the implications of motor development during the infant's life, we need to understand how the motor development happens and how do they go during the first years of life. So, the motor development is defined as a dynamic and continuous process of changes and refinement of motor behavior throughout the life cycle. Under the influence of intrinsic factors as structures and body functions, activities, participation, personal and environmental factors too. Here in this presentation you are going to see that we are going to use a lot of ICF terms and to understand how this process works. And the sequence of emergence of posture, movement, and activity patterns is predictable and age-related, but not age-dependent, becoming increasingly complex over time. So the presentation and the line of research of Professor Eloisa is very similar to the previous presentation, especially from Professor Audrey about the motor development and how it happens. And the sequence of motor development is genetically predetermined, but the rate of emergency is influenced by the context. So it's very important to understand that the environment and the context that the infant lives and go during his life, the motor development life, influence a lot his performance. And age groups represent the approximate time at which certain activities might emerge. So, motor milestones guide the typical motor development. It's not age-dependent, but they guide how the typical motor development is going and if it has some atypical behavior happen in that time. And some factors influence this motor development throughout the life, and they can be risk factors or protective factors. So risk factors increase the chance that the outcome of motor development is negative, and protective factors increase the chances that the outcome of motor development is positive. And here we can see some examples of these risk factors and protective factors. So we can see that biological factors, for example, the genetic, has as risk factors the genetic alterations, and protective factors the genetic counseling. Gestational age, that is also a biological factor, has as risk factors the age of the gestational age under 32 weeks, and protective factors more or equal than 37 weeks, and the birth weight under 1,500 grams as risk factors, and as protective factors more than or equal to 2,500 grams. And environmental factors, we can see, for example, the maternal age that has risk factors under 40 and more than under 14 and more than 40 years, and protective factors between 20 and 35 years old. Parent education, it has as risk factors illiteracy or incomplete elementary education, and protective factors more than complete elementary education. Per capita family income, risk factors is up to half minimum wage, and protective factors more than half minimum wage. That in Brazil now we have a minimum wage of 1,200. And environmental itself, it has as risk factors impoverished and unsafe environments, and protective factors enriched and safe environment. And these are just some examples of factors that might influence the motor development, because we have several more than that, but we just select some to exemplify. And And besides the definition of motor development, we also have some characteristics that are very, very, very important to understand, and that will guide if it is a typical or atypical development. So we have a development that is cephalocaudal direction and proximo-distal direction. We have a lot of variability during the motor development. We have gross motor abilities come first, then fine motor abilities, and a lot of other characteristics that help us. And one of the main characteristics, it's also in the same line of neuronal group selection theory. I wrote this to not forget the order of the words. So neuronal group selection theory that says that the baby starts in a primary variability. So he experienced a lot of movements in different directions, different speeds, in different planes of movement. And after this experience, he can select the best motor strategy to perform a task, to perform an activity, and that is the secondary variability. And with that in mind, we can assure if a movement, if this development is being typical, because what characterizes an atypical movement is this the lack of variability in the movement. So that is very important to understand how it happens. And it's important to remember that motor development begins in embryonic and fetal life, as the last lecture already says. So birth, it's not an interruption, but a continuity of learned movements that will increase their complexity due to the action of gravity. Because in the womb, it was in one type of context, it was one type of environment, and then after birth, we have the force of gravity that is very difficult to the baby learn, to the baby to have his movements, so you will increase the complexity. Here we have a figure that helps us to see how this embryonic and fetal life happens. So this line, this black line, shows the range of age that an ability could start happening. So they will continue during the rest of pregnancy, but that is the range that could start. So, for example, we have movements of the arms, movements of the legs, we have movements of kicking in high frequency, we have movements of head orientation, and they start very, very soon in the pregnancy, and then they continue showing that the baby already learned in the fetal life. And for example, we have the suction behavior, and the baby already born with variability, secondary variability in suction movement. So we have this difference in each ability. It's in one phase of variability. And these movements, these active movements that the baby has in the fetal life, the reflex movement and the active movement, the same way that they have since they are born, are very, very, very important to the neuroplasticity, because then we have a lot of synapse formation, and we have a lot of myelinization that only can be happen in a good way, in the way that we need to happen if the baby has these active movements, not passive movements. And to be possible to change the course of the development, we need the health promotion during the early childhood and since before the conception. So before the conception, we need to, it would be great if the parents could have parenting counseling so that they can see how the genetic is going, emotional and psychological prepare to receive this baby, to receive this child. And after conception, during the pregnancy, and after the baby is born, it's very important to stay in this health promotion and understand the motor development and the importance to know him to understand and change the course of the motor development if it's necessary. And that can be happen with early detection. So MRI is very useful to early detection, but it's not a reality in a lot of cities and a lot of countries. So in our city, São Carlos, MRI is not a reality. So we need to have another tools to detect this development and possible atypical signs in motor development. So some examples of these assessment instruments are Hammersmith Infant Neurological Examination, General Movement Assessment, Infant Motor Profile, Movement Assessment of Infants, Test of Infant Motor Performance, and Alberta Infant Motor Scale. Professor Eloisa team is already validating the infant motor profile to Brazilian culture. So they are doing the translation and the data collection for normative data here in Brazil. And these instruments also help us to talk with the family. So we can show them in a visual way how this development is happening, because sometimes when we talk we are not very clear because maybe we use some technical terms and it's difficult to understand what we are saying, but when we make possible to then visualize in an assessment tool, then we can have a more honest conversation. So it's very important. And early intervention is only possible with early detection. And now we are going to talk a little more about early intervention. And Professor Eloisa has a definition for early intervention. That is, early physical therapy intervention is a secondary prevention treatment approach. It is destined for newborns and infants at risk for alterations in neurosensorial motor development, regardless of health condition. And that is very important because it doesn't matter if the baby already had a diagnosis, a health condition already is there. Just a risk for the development, for the motor development, it's already enough to start an early intervention. We don't need a diagnosis of cerebral palsy or any other condition to start the intervention. And the early intervention should initiate by the 4th month of chronological age. That is an age very that Professor Eloisa already defended, because it's when the neuroplasticity it's happened the most during the early childhood, and it's before the emergency of a lot of important activities that the baby will perform. So before the reaching, during the head control, so before the emergency of these abilities. And it's chronological age because the aim of the early intervention, it's always put together the chronological and the correct age, so the baby don't stay in the correct age, don't stay with the delay in motor development. And early physical therapy intervention allows the habilitation and not the rehabilitation. So the baby will be learning and not relearning, because doesn't have learn and ability. So it doesn't have any wrong pattern or anything like that. So he will learn how to do an activity, he will learn how to perform a task. And it's a multifaceted and interdisciplinary process. And one of the main justifications for the early intervention, especially in this age, is that neuroplasticity is the basis of learning in the normally developing brain and relearning in the injured brain through rehabilitation. And neglecting this critical and sensitive period of the central nervous systems imply missing the best opportunities of offering interventions that could contribute to development of various systems, such as neurosensory motor, cognitive, and musculoskeletal. So it is the best period, it's the best age of thinking about neuroplasticity to perform an intervention. And here in this figure we can see that the sensory capacities, the sensory abilities, it has their peak during the 3 first months of life. That also shows that the synapses formation are higher during that time, so it's another reinforce that justification of the age of early intervention. And in this other graphic, we can see some brain activities happening during the pregnancy and after the birth. So, for example, the neurogenesis in cerebral cortex that has their peak during the pregnancy, but it also continues through life. We have synapse formation that has their peak during the pregnancy, and during the first year of life we have myelination that also it happens in the pregnancy and during the first year of life. So we have a lot of neuroplasticity happen during this time. So the ideal age to start early intervention is the first 4 months of age, because in that way we are preventing the emergence of secondary impediments to structures and functions of the body. In that way we are going to minimize limitations on activities, better performance during the execution of activities, and we are going to favor personal and environmental factors as facilitators of motor development. And in this sense of understanding the motor development and how this motor development can interfere, can change the course of the motor milestones and all the development of the baby, Professor Eloisa has several research in the line of research at Núcleo de Estudos em Neuropediatria e Motricidade, NENEM, that is our lab at Federal University of São Carlos. So one of the first research of Professor Eloisa in reaching was early control of reaching, effects of experience and body orientation, and was performed in kinematic and qualitative analysis of reach in full-term infants at 4 to 6 months old. So it was a longitudinal study, and the infants were positioned in different positions. There was supine, reclining in 45 degrees, and sitting position in 7 degrees. So the results showed that the reclining and the sitting position turned possible to the infant perform a better reaching. So when the infant is reclining or sitting position, the reaching behavior is easier than supine position because of the gravity action. Other studies about reaching, other studies in reaching are proximal and distal adjustment of reaching behavior in preterm infants, and additional weights influences the reaching behavior of low-risk preterm infants. So with the additional weights in the wrists of the infants in a reclined position, we can saw that the additional weights increase the speed that the reach was performed, because if they were in a low speed, they will need more adjustments during the course of the movement, so they increase the speed of the reaching. So if the goal of the physical therapist is to work in the strength of the upper limbs, for example, it is a useful tool to additional weights in the wrists. But if the goal of the physical therapist is to work in the grasping and manipulation, it's not a tool so useful, because it's difficult to the baby to grasp and manipulate the object with an additional weight. And the proximal and distal adjustments, comparing with full-term infants and preterm infants, doesn't show any difference between the groups, so they don't change the distal, that is the hands movement, the hands adjustments, and the proximal adjustments, that is the shoulder movement. And the age of the babies was also in the 4, 5, and 6 months of age. This other study showed the development of reaching behavior in low-risk preterm infants. So also the both groups doesn't have any difference between the groups, the full-term infants and the preterm infants, but both were able to reach the object, but the preterm infants performed a slow movement. They were able to reach the object, the toy, but in a slow speed than compared to the full-term infants. Also in the same range of age. This other study about the adaptive actions of young infants in the task of reaching for objects. So it was performed a kinematic and qualitative analysis of reach in full-term infants, also at 4, 5, and 6 months of age. And they were presented a malleable object and a rigid object. Also represent different size of objects, so small ones and big ones objects. The malleable, the baby reach, grasp, and squeeze the object, so they have a manipulation behavior. And the rigid object, they didn't grasp or squeeze or anything. They just hit in the object during the presentation. And the bigger objects, they performed a bimanual reach, and the small objects, they perform an unimanual reach. So they understand how they should perform the reach so that they have success. This other study about the development of exploratory behavior in late preterm infants showed that the babies start with less complex exploratory behavior. So they bring to the mouth, they squeeze the object if it's malleable, and during the first year life they increase the complexity of the exploratory behavior. So they start to hit the toy in other surfaces and change the hands of the object. And they use these experiences in exploratory behavior for more complex activities, as feed themselves around the 6 until the 12 months of age. And besides research in evaluation of the reaching movement and other movements, Professor Eloisa also has some studies with the effects of training the reaching movement. So these three studies will be shown right now. So it was tested the effect of short-term training comparing preterm and full-term infants. So the protocol that the team developed was to perform a tactile stimuli in upper limbs, then present the object in the midline of the baby, and then wait for the active movement of the infant. And you can see that the infant is in a reclined position in the lap of the researcher, and with a pillow in their head, so that the movement could be easier to him perform. And the same protocol was also performed in these other two research. The difference between them is that in this research the baby was extreme preterm. In that research was low risk preterm, so moderate preterm. And in this research was full-term infant. And in all of these studies, the results was positive. So the short training was successful. So the baby presents a higher frequency of the reaching movement after the training. And the same protocol was also performed in this other study, but it was using gloves with Velcro, so that the baby, when the baby reached the object will stick. They will stick in the hands of the baby, and then that was the difference in the protocol. And the babies were at environmental risk, so in vulnerability and not in biological risk. But it doesn't show difference between the groups. So the group that performed social training, so just interaction between researcher and physical therapist and baby, also the baby performed the same frequency of reaches. We also have a lot of research with head movements, so in different positions, so just in supine, then with a pillow in their head, and then in a reclined position, and in the infant heads between 0 and 4 months. And this research showed that the head movements increase their frequency from 2 months. So the 0 from 2 months, they have certainly a frequency of head movements, and from 2 months this frequency increase. Also, we analyze kicking movements of the babies to see the frequency of movements, the sitting positions and level of trunk control during reach movements. So we also use the segmental assessment of trunk control, that is the SATICO, an instrument to see the level of trunk control. And when the baby is receiving support in the exact level trunk control, they perform a better reach movement. And our team also developed a protocol for training trunk control with active exercise. We also have, Professor Eloisa also have a research with children a little older, a lot older, with between 6 and 11 years old, to study developmental coordination disorder, DCD. So besides movement ABC and the other instruments for evaluation of DCD, we also perform the KTK evaluation, and also the evaluation and the intervention with Wii and Xbox with dual tasks. And then Professor Eloisa brings all this knowledge from her research to our clinical practice. So the results that she obtained with her research, she brings to our practice so that we can apply what we see in our lab. So we have a program of early intervention, Núcleo de Estudos em Neuropediatria e Motricidade, NENEM, that is a postgraduate program that it calls Aperfeiçoamento in Early Intervention for physical therapists and occupational therapists. And here we can see different body positions to work with the head control, so we can work with head control, training the head control in a ball, in supine with a towel, in baby's chest, in supine with this is a pants with spuma. Inside, so that we can use with the baby. So we help with the flexion posture, supine position reclined, and supine position reclined in the physical therapist lab. So we can work with reach movements and with head control. Reach movements in different positions too, so sitting in the lap of the physical therapist and kneeling in the lap of physical therapist. We train our baby with additional weights in the wrists. So during the supine position, in a reclined position, and just in supine. So we present an easier way to do, and then we make a little more difficult to train. Also reaching movements in different positions, so in prone, with help, in chest, and supine with inclination in the head, and standing. Also training the reaching and grasping activities. The exploratory behavior from their own body, so with their foot, with their hands, and then with toys, so that they can shake and bring into their mouth. And then in babies a little older, we see a more complex behavior of exploratory. So the baby is hitting with the chocalho here, and change the hands of the object and hitting the object in the other hand. We have also a head control movement using a figure with a lot of contrast, so the baby can fix the eyes in the object in a reclined position. It's a little video. So the baby could follow the image, the figure. Sorry. The fixation in toys in different positions too. So reclined in the lap of the physical therapist. The kicking movements with toys too, so that the baby could be interested in kicking the toy. Kicking too. And you can see that we have different health conditions in all these babies. So just to reassure that we don't need to wait for a health condition to start the intervention. And here we have a figure that is published in one of the articles of our team that shows some strategies of some early intervention strategies that works with ICF components. So we can see the participation of the baby, the activity, and the body function that is related to this early intervention strategies. So for example, local motor space in an object's head control, palm orientation, stimulation of different postures, perform kickings. So everything that we do in our clinical practice, it's aligned with ICF components. And this whole presentation was based on two mainly references. There is two books of Professor Eloisa. There is Early Intervention, Evidence for the Clinical Practice at Infants at Risk, and was published in 2019. And Neuropediatric Physiotherapy, Biopsychological Approach, that was published in 2021. And that's it. That is the email of Professor Eloisa that you can contact her. And that is some reference. So thank you.
Thank you.